All right. So my name is Dr. Edward Rosero. I'm not Dr. Edward Rosero. I'm one of the former residents here. I graduated here, I think it was 2013, if I remember correctly. Right now I'm a pulmonary sports medicine doctor at orthopedic care, but soon to be Rothman Orthopedics because they, like the Borg, simulate us, and as of January 1st, we will have the same tax ID. I'm here to talk to you about non-invasive and invasive interventions for chronic tendon pain or tendinopathy. All right. This lecture should only go about 30-40 minutes, so if you have any questions, feel free to hold on to them to the end, okay? All right, so my objective is to provide a general understanding of tendinopathy and go over evidence-based review of treatment options. I'm going to do this by defining tendinopathy versus tendinitis, talk about all the treatment options, and I'm going to make some final recommendations at the end of this lecture. I don't have any financial disclosures. So what is tendinopathy? Tendinopathy is a clinical syndrome of overuse associated with impaired healing, resulting in prolonged pain, tendon thickening, diffuse or localized swelling, and impaired performance. Now, in terms of tendon disease, it's a spectrum that goes from tendinitis all the way to tendinosis. In tendinitis, this is the acute stage. This is the first stage that you usually run into. In this stage, you get degeneration of the tendon with vascular disruption and an inflammatory repair response. This is where you get bringing in of inflammatory mediators to help repair the acutely damaged tissue. Unfortunately, if you constantly damage that tissue, eventually the inflammatory response runs out and it becomes a tendinopathy or tendinosis. This is that chronic tendon pain that we run into. In here, the inflammatory response is actually gone, and all you get is degeneration, trauma, and vascular compromise. There may be some scarring. There also may or may not be some neovascularization. Now, over on the left, this is a pathological side of normal tendon tissue. I don't think this works really well here, right? All right. So what you can you see my arrow? All right. So what you see over here is you have parallel bundles of uniform appearing collagen oriented along the long axis of the tendon. It looks nice and uniform, right? Just like on our cadavers. But if you look at these slides, if you're on the left, this is a pathological side of severe tendinopathy. These pale blue regions here represent abnormal collagen and matrix production. And then the red staining, as you can see here, here, and here, this is angiofibroblastic hypoplasia throughout the tendon. Over on the right, you have a similar slide with vitamin stain, which shows widespread cellularity, but it's in a random orientation. It's not nice and linear like these tendons down here. So in tendinopathy, the collagen, it's in a state of disrepair. It's not healing itself correctly. The tissue repair response is altered, and the tendon realigns itself in abnormal orientation. The pattern is similar whether it's in the upper extremity or lower extremity, it doesn't really matter. And then again, there may or may not be hyperemia or neovascularization. The reason why there is neovascularization, we're really not quite sure. It's just something that we find in we notice under ultrasound guidance. Now, who gets this? There are certain intrinsic and extrinsic risk factors associated with tendinopathy. When we're older than 35 years old, our collagen turnover slows. We tend to have crosslinks which accumulate between our fibrils and leads to stiffer tendons. So that puts people at risks. Gender does play a role. For example, males for some reason are more likely to have patella tendinopathy than females. It's not really understood. It's theoretically maybe due to hormonal differences or biomechanical differences, such as how women have wider hips than males and leads to an increased Q angle. Going to biomechanical abnormalities, for example, with Achilles tendinopathy, arch types may play a role. If someone has high arches or even flat arches, they're more prone to Achilles tendinopathy as opposed to someone with normal flat feet, normal arched feet. And then if you have a prior tendon lesion, there was one study that showed that if someone had a small tear through their Achilles tendon, it could lead to a chronic tendon issue by the end of the season. Then finally, genetics. People are more prone to have bilateral tendinopathy, say in their patella tendons or Achilles, as opposed to someone else. Now, extrinsic factors include, these are simple ones, where training errors, where someone either goes too hard too quickly, or someone is just doing the same thing over and over again without changing it up. In addition, poor environmental conditions and inadequate equipment can play a role in developing tendinopathy. Now, speaking more specifically, I'm going to just focus on 3 different types of tendinopathy. Achilles tendinopathy, which is tendinopathy of the Achilles tendon. This has a incidence of 24% in all competitive athletes and about 70% of all running injuries in even recreational runners. Military recruits, you see this in about 6.8% of them. The risk factors include abrupt increase in activity or increased work, poor running mechanics. I think you guys had a lecture by Dr. Galato last year regarding running mechanics, correct? You know, so she kind of went over, you know, good and bad running mechanics. Prolonged activity, improper footwear can play a role. And again, older individuals, male individuals, and also if you're obese, you tend to be at risk for developing tendinopathy. In addition, fluoroquinolone use has been associated with tendon issues. The thought process is that fluoroquinolones, with fluoroquinolone use, you get an accumulation of free radicals, and these can build up in the watershed area of the Achilles tendon, leading to chronic tendon problems. Now, signs and symptoms of chronic tendon pain, you could get burning or stiffness located in the mid portion of the Achilles tendon or at its insertion on the calcaneus. Usually worse with activity and better with rest. In addition, you're going to have some tenderness over the Achilles tendon. Now, you guys see my arrow, right? So on the left, this is a normal Achilles tendon here. What you see here is you have a nice fibrillar pattern with nice homogeneity of the echo signals. And then over on the right, thickened tendon, mixed echogenetic activity right here, all right? Oops. All right, now talking about lateral epicondylitis, also known as tennis elbow. Prevalence about 1.3% in the general incidence and 1 to 3% in the general population. 20% of all racket injuries in recreational tennis players are lateral epicondylosis, though you'll tend to find that people who golf get tennis elbow, people who play tennis get golfer's elbow, so it doesn't really make a difference. Risk factors are almost the same. I mean, obesity, older age, smoking is also thrown in. Repetitive movements, forceful activity, and poor mechanics or improper rackets. So for example, someone who's inexperienced tries to do a higher tension reaction to get more force, they may develop these symptoms. Signs and symptoms include tenderness over the lateral epicondyle and proximal wrist extensor muscle mass. You'll get some pain with resisted extension and supination. In addition, there will be some pain with passive flexion with the elbow fully extended. Finally, I'm just going to talk quickly about patella tendinosis. Again, it occurs predominantly in jumping athletes, but it can also occur in, you know, regular recreational athletes as well. Jumping sports, poor flexibility of the quadriceps and hamstrings play a role. Intrinsic risk factors also include overweight, genuvarum valgum, patella alta or baja, increased Q angle like I talked about before, and then anyone with a limb length discrepancy tend to be at risk for patella tendinopathy. Again, signs and symptoms: anterior knee pain, which is usually described as an aching pain. Palpation along the patella tendon will be painful. It could be anywhere along the tendon, either near the inferior patella pole or actually near the tibia tuberosity. And again, worse with activity, better with rest. Here's some ultrasound images again of patella tendinopathy here. Over here, this is a temple pulmonar resident here who might be lecturing to you right now. I have a normal tendon, as you can see here. Nice, thin, nice fibrillar pattern. Over here, this is an ultrasound image of an individual who has patella tendinopathy. Again, thickened tendon, mixed echogenetic signal. In addition, he has a small micro tear that was actually noted right there. All right, so let's talk about treatment. You know, there's a number of treatments for chronic tendinopathy. This could probably be a 3-hour lecture if you really wanted to go through it all. But what I want to do is focus on the most popular treatments, the most studied treatments, and the ones that people are talking about. These include physical therapy, steroid injections, Nsaids, percutaneous needle tenotomy or PNT, platelet-rich plasma injections, and finally the 10x fast procedure. Anyone see that procedure yet? 10x fast procedure? Had it on the doctor show, and I think one time too. So let's go over
the exercises are performed from the edge of the step.
That's my voice. See, I gave you credit.
The loading will consist of body weight.
Oh, it's coming from the TV, right? Aha. Oh, one sec. Let me see if I can.
You'll be standing with all of your body.
I got it. Don't worry. There we go. Perfect. So, I got it. All right. So, physical therapy is a great starting for chronic tendon pain. I mean, you're a physiatrist, so you should really be thinking about this first and foremost. It tends to be highly underused, and it usually starts with number one, activity modification. If with your history, they'll usually tell you I'm either doing too much, doing too little. I run, but I don't do any type of weight training. Or I don't stretch. These are things that you should be already on top of. Secondly, you want to do some biomechanical modification. This could be altering specific movements, specifically looking at the running mechanics. Also, if it's, say, chronic medial or lateral epicondylitis and it's due to someone who types at a keyboard all day, you might want to take a look at their ergonomic workstation and see if that's an issue, and that's the reason why they're having some pain. Now, the keystone for treatment of tendinopathy is eccentric exercises, which is a careful application of a load to a lengthening muscle. Everyone knows the difference between a concentric and eccentric exercise, correct? You force through muscle, the muscle shortening is a concentric exercise, but then a force through the muscle with a lengthening muscle is an eccentric exercise, all right? This video right here, which of course I stole from YouTube right here, demonstrates a proper eccentric exercise for the Achilles tendon. What you want to do is you start with a plantar flexion off a step if you want to. You can even do off the ground with 2 feet. Then you want to slowly lower on the 1 foot. Usually it's good to do both sides. You don't want to train someone unevenly. And usually your count is a 1 second plantar flexion with a 3 to 4 second dorsiflexion. So you want a 3 to 4 to 1 ratio, so to speak. And that's how you do it. Now, what has been found to, when you do this, it causes some remodeling of the tissue. Remember how it was disorganized in the pathological slides? What you're hoping to do is break up some of that tissue and then cause the tendons to realign properly. In addition, there's also thought that it does diminish neovascularization. Now the question is, does it work? There's been a number of studies which actually have shown it to be very beneficial. You have the studies by these two gentlemen which showed 44% pain relief and 43% function improvement in a group of 200 athletes. It's been shown to be effective for treatment of Achilles tendinopathy. In addition, one study has shown that using eccentric exercises decreased pain for 6 weeks and lasts for about a year without any other intervention. Now, grouped with physical therapy, splinting, taping, and bracing. Currently, really, there is no studies demonstrating strong evidence in support of splinting, taping, or bracing as being superior to eccentric exercises. That being said, a lot of people are doing them in combination. I really couldn't find any studies looking at them in combination with eccentric exercises. But from my point of view is that if they find it beneficial where they use K-tape, splinting, bracing, in addition to their eccentric exercise, I say more power to them. I'm not going to stop them from doing it.
Is that all tendon? Is that all upper and lowers?
That's correct. What the heck just happened?
Bathroom.
Ah. So anyways, how are you guys doing? That's the end of my lecture. I didn't know if you guys knew that. When I found out it was being recorded, I had to stop when it came to stuff that I stole. I'm only kidding. I didn't steal anything. I didn't steal anything. All the students got? You guys get rid of all the students? Oh, jeez. Yeah. I don't know. I'll find it. There we go. Don't worry, guys. I'm Asian. I'm good at this. All right. So let's talk about corticosteroid injections. Corticosteroids have been used widely for a variety of musculoskeletal treatments in orthopedics, sports medicine, rheumatology, so forth and so on. In fellowship, they always called me the needler because I was always thinking about sticking a needle in them before I was even thinking about examining them. But they are still, corticosteroid injections are used widely by orthopods in treatment of chronic tendon pain. I know a bunch of my colleagues, especially the hand guys, love using steroid injections. But the question is it effective? All right, it's used a lot, so why is it effective? So this is a systematic review which was used to summarize the effects of corticosteroid injections on a variety of different tendons and tendon tissue. What they were looking at is collagen organization as well as mechanical properties of tendon after the corticosteroid injection. By the way, I talk fast, so if I'm talking too fast, let me know. Now, in terms of collagen orientation, there were a large number of studies which demonstrated loss of collagen orientation and reduced proliferation and viability of fibroblasts after the corticosteroid injection. There are 3 studies that showed actually collagen necrosis after the CSI. There are 4 studies that actually showed increased inflammatory cell infiltrate, which is interesting because you figure steroids are an anti-inflammatory. So it's actually interesting that you're getting an increased inflammatory response with it, which could be good and bad if you think about it, because if you're well, we'll get to PRP, but if you think about it, if you increase inflammation, then maybe you're increasing the healing of the tendons. But interesting enough that throwing a steroid, which is anti-inflammatory, caused a increased inflammatory response. And then finally, a number of studies did show some apoptosis within the tendon. Now, this forest plot depicts a number of studies which looked at mechanical properties of the tendons after a corticosteroid injection. As you can see here, over on the left side here, this shows decreased mechanical properties or decreased tension. Over here on the right would be increased tension. Now, what you want to think is for tendinopathy, you want to increase the amount of tension that you have in the tendon to make a stronger, more functional tendon. But as you can see, that none of the majority of people in the long term did not really show any change, and actually it's more on the decreased mechanical properties or decreased tension side. So you can see that it doesn't really help with strength of the tendon, so it really doesn't seem to help with what we're trying to accomplish. Only really 3 showed improved mechanical properties after the corticosteroid injections. So what they found was, 1, there's negative effects in tendons in vitro. There's increased collagen disorganization and necrosis in vivo with reduction of mechanical properties. So in summary, corticosteroid injections, which are quite used frequently in practice, show no real benefit for use with chronic tendinopathy, and actually have the potential for an instance of injury based on the damage to tendons at the cellular level. I mean, I don't feel like I'm saying anything that's really groundbreaking. If you look at most of the lectures in the past 3 years, even at AAPM&R, all of them will say, yes, I agree. Injecting steroids in a tendon is bad. But I'm just saying it too. Now, because the tendinopathy is a chronic degenerative change and not an acute inflammatory issue, I expected similar results with Nsaids when I looked at it. If you look at the number of the studies here, one study, I mean, it's an old study back in 1992, looked at 70 patients with Achilles tendinopathy. And they used the NSAID piroxicam, and basically didn't really show any difference using piroxicam versus placebo in terms of outcomes of pain, swelling, stability, and muscle strength. Another systematic review by Condon 2011, Bissett 2005 showed lack of benefit of NSAIDs past 3 months of tendon pain. Makes sense, right? Because past 3 months, that's when you're out of the inflammatory response. So you're not treating inflammation at all. You're just treating a painful tendon. Finally, which kind of backs up the second line, is NSAIDs show benefit only in the short term only by those 4 studies. So value in the short term may provide some temporary relief, but it's not really, in my opinion, it's not recommended as a good treatment for chronic tendon pain. All right. Percutaneous needle tenotomy. You guys are doing ultrasound more these days, right? No? Someone said no. Yeah? Have you guys done any PNT? No? I'm sorry? Not with Weinig? Okay. So what is percutaneous needle tenotomy? What happens is you take a tendon, which is painful, and you find that it does have evidence of tendinopathy. And what you do is you take a needle and fenestrate it about 30 to 50 times to induce bleeding and disorganization of the to damage the disorganized tissue to hopefully cause it to remodel. That clot formation hopefully induces a healing response, and the goal is to turn non-healing tissue into healing tissue. This is an example of one that I did back in fellowship. What I'm doing here is, this is a patella tendon, as you can see, sorry, right here. Do you see that? Oh, it's just delayed, sorry. So what you see here, this is the patella right here, patella tendon here in long axis. And what I'm doing is I'm hitting actually the patella tendon interface right here, where this right here, up here is normal tendon, but down here you can see it's thickened. It has a mixed echogenicity. So I'm attacking that area over here. What I'm doing is I hit it about 50 times. I use just lidocaine for analgesia after I hydrodissect it. And then we let them rest for about a week without use of any anti-inflammatories. And then afterwards start an eccentric exercise program. So the question is, does it work? You know, does it work? This one author, McShane, he actually did a similar study with percutaneous needle tenotomy combined with a steroid injection, which worked for him. So he wanted to see, is the steroid necessary? So he did a follow-up study to see if just a PNT alone will provide relief. In his study, it was 57 patients with lateral epicondylitis, which failed non-surgical treatments with steroid injections, Nsaids, and cock-up wrist splints. He used a 20-gauge needle, performed a percutaneous needle tenotomy under ultrasound guidance, and then afterwards put them in a formal physical therapy protocol. Again, no NSAIDs. And then his outcome was a modified patient-rated eval form at 22 months after the procedure, and he was looking at pain, ability to perform tasks, and overall procedure-related improvement. So the results were gathered via telephone interview. And what happens is 80% of the people reported no pain after 1 week of treatment, and then 96% reported no painful wakings in the middle of the night after treatment as well. In terms of functionality, the majority of patients reported no issues with functionality after the procedure. They asked a number of questions such as turning a doorknob all the way to performing the usual job, and difficulty from none to unable to. NA means just it, for some reason, I guess one person never lifted a cup or glass to their mouth in their life. So I don't know, you got me on that one. So, but most of them reported limited, no impairments in functionality after this study. And then when it comes to satisfaction, about 57% reported excellent satisfaction, 34% good satisfaction. So overall, majority of people were somewhat happy with the study. So conclusions from the study that, you know, percutaneous needle tenotomy for lateral epicondylitis is a safe and effective treatment without cortisone required. It did have a couple limitations, meaning that is a retrospective study. There are no specific functional abilities tested because they talked about functional abilities. I don't know if they're talking specifically, and there's no control. It's kind of hard to have a control in that study when you're sticking someone with a needle. Then finally, this other study looked at percutaneous needle tenotomy and other tendons besides the lateral epicondyle. These were 14 tendons across 13 patients, which is a mixed bag, as you can see up there. They did an ultrasound-guided percutaneous needle tenotomy, and they rested for about 4 weeks with gradual return activity after 4 weeks. And I evaluated at 4 and 12 weeks, and the main outcome looking at was pain. As you can see here, they had a drop in pain from about 3+ points of pain after 4 weeks, and it lasted over 3 months. So in conclusion, they noted that it's a good treatment, that it's a viable treatment for chronic tendinopathy. Now, again, the limitations of this is it's an inhomogeneous group. The previous treatments that they had for this were not standardized. They took anyone who just failed, quote unquote, treatment. No control, no blinding, and the follow-up period was only a couple months. So, and also they noted no sonographic follow-up as well. All right, so let's talk about platelet-rich plasma. Have you guys done PRP here? No, I admit it's kind of hard to do up here in this population, but.
Not here in Moss, but yeah, on some rotations.
Galata, right? Yeah, she does it quite a bit. So PRP, it's a very popular but controversial method for treating chronic tendon pain. A lot of practices, such as Galatas, are using this procedure. As you know, it's still considered experimental, so it's usually not covered. In this area, I mean, well, it depends on where you go. Price is going to be as low as $500, but as high as $1,000. What happens is there's a sample of your blood with concentration platelets, and what they do is they spin it down till they get the platelet-rich plasma. In the 1950s, they've been using PRP for a number of treatments. I actually have a colleague of mine. She's family medicine. She does beauty medicine in Miami, and she is rich. And she's like 1 year out of of residency, so she's happy. But they've been using PRP to treat wrinkles for a long time. PRP contains a number of growth factors in high concentrations. Number one, platelet-derived growth factor, transferrin growth factor beta, and vascular endothelial growth factor. The main thing is that these growth factors are used to initiate an inflammatory response and start angiogenesis and tissue healing. Now, more than 40 commercial systems exist. Of those commercial systems, they all have variable platelet concentrations. There's one study that showed that proved that a lot of these different systems, they're all different. All of them are different in terms of how much blood volume they get, how much platelets they recover, the final volume of plasma they actually end up getting from the volume they collect. And then some you do or do not use thrombin. Now, thrombin, it's necessary in the clotting cascade. So, you know, it's something that you figure you would need with every single PRP injection. However, you know, there's some evidence that thrombin may actually diminish bone formation compared to non-thrombin PRP. So a lot of people are saying, I don't know if we need to use that or not. In addition, hasn't ever been proven that there's a linear dose response curve ever demonstrated. So example, doing 20 mLs of PRP versus 60 mLs of PRP for a single tendon really doesn't matter. Rule of thumb, it's been stated that if it's a smaller tendon, 20 mLs, larger tendon, 60. Now, the question is, does it work? So this study came out about 2 years ago in the Purple Journal. As you can see, we got the big names on there. We got Mountaineer, we have Malanga. And this was a large study across 4 academic sports medicine centers in the US. Retrospective cross-sectional. And what they did is they contacted patients who had PRP performed on them to see whether or not they're happy or not. It's anyone over the age of 18. They had to have a diagnosis of tendinopathy for at least 6 months, which was confirmed via imaging, whether it's ultrasound or MRI. They had to fail with conventional treatments, whether it's oral medications, physical therapy / modalities, as well as the Eccentric Exercise program, which you talked about before. And then they had an ultrasound-guided PRP injection. The survey had to be a minimum of 6 months after the procedure was performed. Now, how many injections did you get? That was a big question. Now, with the paper, if you reported, I'm 80% better, you got only one, you stopped getting injections after you were 80% better. If you're less than 80%, but you tell the doctor, yeah, I'm better, I feel like I'm getting better, then they wouldn't inject you again. If you're under 80% and you said, I'm not getting any better, they would repeat the injection. The outcomes that they're looking at is perceived improvement of symptoms at 6 months. It was on a 5-point scale, which went from all the way from not at all improved to completely resolved. Secondary measures they looked at was the visual analog scale, functional pain, and overall satisfaction with the procedure. So here are the results. In terms of primary outcomes, 82% reported at least moderate improvement in their symptoms after they had PRP. Now, broken down with the exception of the patella, you can see that about 81% reported at least moderate improvement. So it's a decent study. It's not fantastic, but it does show that people are showing benefit with PRP. Now, of the PRP injections that they did perform, of all those of the collected, 60% got 1, 30% got 2, and 10% of the people they surveyed got 3 or more. Of the individuals who got through, who had these injections, after 1 injection, 80% they were at least moderately improved. 82% after moderately improved after 2 injections, and 76% after 3 or more injections. Now, in terms of the secondary outcomes, there was a decrease in about 5 points in the visual analog scale. 68% reported no pain with activities and minimal pain before or after. 20% pain with activities but no ADL disruption, and 5% wish they pretty much never had it. Overall, 85% were satisfied, 13% dissatisfied, and 2% indifferent. So with this study, which is really recent, shows that this is the large database of patients that were treated with PRP for tendinopathy, and it showed significant improvement in their symptoms, and patients were happy with it. The limitations, again, it's a survey, and they only got about 1, a little over half of the people respond, so there could be some bias in terms of who they got. There was no long-term follow-up. Their rehab programs that they did before and after were not standardized. Again, retrospective data, so there is possible recall bias. And then there's no information regarding what kind of system they use or how much platelets they add, leukocyte levels, activator, and all that good stuff. So, you know, in my opinion, is PRP a viable option for treatment of chronic tendon pain? I say yes, as long as they failed with all conservative measures, taking into the fact that you have a study that shows some people have perceived benefit from it. And two, you know, what's their alternative? Now, again, I told you it's still controversial. You know, it's still being debated about how efficacious it is. There's been 2 decent studies going against PRP, both pretty much by the same author, Dr. DeVos over here. I think he's an orthopedic surgeon, if I remember correctly. He did one study that looked at PRP on PRP injections, looking at neovascularization in chronic mid-portion Achilles tendinopathy. So the thought process is if PRPs can interrupt the neovascularization, cause tendon remodeling, they should have less pain. So he wanted to see whether it really changed anything with the ultrasound. So he did a double-blind, randomized, placebo-controlled trial with 54 patients with chronic mid-portion Achilles tendinopathy. He had 2 groups. One group who had eccentric exercises with PRP, and the other group with eccentric exercises with saline, which is our control group. Main outcomes he was looking at was tendon structure and looking at neovascularization under ultrasonography. And follow-up was at 6, 12, and 24 weeks. What he found was that there were significant improvements in both groups with tendon structure at 24 weeks and no significant change in neovascularization between the 2 groups after 6 weeks. So basically, what he found was that injecting PRP for treatment of chronic mid-portion Achilles tendinopathy does not contribute to an increased tendon structure or altered degree of neovascularization compared to placebo. In addition, he did a follow-up study, which he did a systematic review, looking at several studies for chronic lateral epicondylosis, excuse me. Of these 6 studies, 4 were considered high quality, and what he found was that there's strong evidence that PRP injections are not efficacious for the management of chronic lateral epitendinopathy. So again, you know, the debate goes back and forth, and you know, with these studies, you know, these are reasons why I think it's being pushed not to be covered. So finally, I want to talk about the 10x FAST procedure. You guys have heard of this procedure? Yes, maybe so. All right. So 10x FAST procedure, or focused aspiration of scar tissue. This was developed in collaboration with the Mayo Clinic, and I took this right from their website. It's a procedure that is a gentle method for percutaneous cutting and removal of diseased tissue and restoration of natural tendon and soft tissue function. It can treat rotator cuff tendinopathy, medial lateral epicondylosis, Patella tendinopathy, Achilles tendinopathy, as well as plantar fasciosis or fasciitis. So here's a video that I took from their website again. Now what happens, this can be done in the office under a local anesthetic. What you do is you localize the tendon that you're going for. You use a small scalpel to just make a small incision because the probe is about an 18 gauge probe. You bring it down to the level of the tendinopathy, and what they do is you end up irrigating the diseased tissue, and then they use a ultrasonic tip, which basically does a PNT on steroids, or just a super percutaneous needle tenotomy of the area. And then what they do is they aspirate the scar tissue out. The anticipated recovery time, they say, is about 2 to 6 weeks. This can be done in the office, but most people are doing them in procedure suites because you don't really make money off them doing the office. You need the procedure code to get it paid for. But does it work? That's the main thing we're looking at. There was one study that they did on it, which was a case series of 20 people in China. There were 7 males, 13 females with tendinopathy lasting for about a year, and they failed conservative treatment, as they should have by the time they get to this study. They looked at outcomes at patient satisfaction, pain, DASH scores, and ultrasound assessments at 3 and 6 months. So in terms of pain, their pain dropped significantly over 12 months, with actually their pain getting improved most significantly in the first several weeks, and it continued to stay low throughout the year. In terms of their DASH scores, or disability of arm, shoulder, and hand score, that also improved with the use of the 10x FAST procedure. Now, in terms of changes in features, looking at the tendons under ultrasound evaluation, a lot of them show decreased hypervascularity, decreased tendon thickness, and absence, or decrease of that hyperechoic lesion. And overall, more than almost everyone but one patient was somewhat satisfied with the procedure. So it does seem to be a safe and well-tolerated alternative treatment with early efficacy and patient satisfaction. But again, this is a case series and not a controlled trial, and it was only done for about a year. So people are doing it now. You know, right now I've not done it myself, but I've sent a couple athletes to get this done, and they've been happy with it. But I've only 2. All right. So finally, I'm just going to make my final recommendations. The best treatment for tendinopathy is prevention. You know, as physiatrists, you guys should be able to hone out people, especially if you meet them early on, who have tendon pain, and be able to prevent them from going from tendinitis to tendinopathy. Whenever you meet these people with chronic tendon pain, it is reasonable to start with an eccentric exercise program. Nsaids, again, in my opinion, they're only beneficial in the short term. Now, granted, if someone's saying, I have pain, can I have something? Yeah, you can give it to them for pain, but it's not going to fix their problem. It just might make them feel better. Corticosteroid injections, I do not recommend them. I've been gently trying to talk some of my partners out of using them, but some of them are just pretty much steadfast in their ways and they get results from them. So, but I don't, you know, whenever a patient comes into me and asks me for a corticosteroid injection because they've had one before or they know someone has one, I usually tell them no. After a year and a half of practice, I've only injected one guy just because he was just adamant about it. He was a nice enough guy, so I kind of folded and I said I did, and I've heard from him since. I assume he's better. And then you want to consider those more invasive procedures if conservative measures fail. The reason why you only want to save them for afterwards is because they can be expensive. Now, percutaneous needle tenotomy in Pennsylvania is only covered for medium lateral epicondylosis. It's not covered for Achilles, Patella, or rotator cuff. Again, PRP is not covered by anyone. 10X strangely is covered, but you need to. Most people aren't doing it unless they're doing it in the procedure suite. So, in conclusion, chronic tendinopathy is a degenerative process resulting from overuse injuries. There are a multitude of treatment options which exist, both conservative and invasive, and then ongoing research on invasive treatments is needed before they can recommend for definitive treatment or at least a more regular treatment. I'm done. Questions? You don't have to clap. Yes.
Disclosure, I'm going to be doing a talk on regenerative medicine.
Yep.
Chronic viral epicondylitis.
Yep.
But does Voss talk about platelet concentration with PRP? Just because there's been a few studies that have looked at, you know, the differences in the concentration level.
No, he did not, and I think that's one of the the pro PRP people are constantly trying to shred his studies so they can prove that PRP works, and that's one thing they said is never looked at platelet concentrations, and then it is theoretical that the higher the platelet concentration, people do get better results. But
what I'm saying, there are actual studies that have looked at platelet concentration being a big difference. So it's not just like, you know, just a reason to shut. I mean, I feel like people have determined that too low of a concentration really not a good benefit. So that's why I'm wondering if there's a reason that he excluded what his concentration was.
Don't know. You know, sometimes people will take a study. You know, they'll present their data. Can't remember if he just used one type of system. So you know, and maybe wasn't even interested in that. You know, it's just the act of just doing PRP. Yes.
The next procedure, do you need like a weekend course, or you just more of the thing and you're good to go?
Honestly, you just need the thing. You're good. The honest answer is you just need the thing. You're good to go. You know, I mean, I was in the process of trying to start doing this at my practice, but we just kind of abandoned it due to financial reasons. But honestly, I asked the guy, I was like, do I need a course? He's like, nope. You know, he's like, do you know how to use an ultrasound machine? I'm like, yep. He goes, you're good to go. So that's pretty much it. Yes.
So the video was really pretty.
Oh yeah. Absolutely.
The delineation between normal tendon and scar tissue, so easy to see.
Well, yes. I mean, well, I'm not talking about scar tissue, but talking about at least tendinopathic tissue. That's easy to see. You should be able to see that on ultrasound. If you YouTube anything, if you use a YouTube 10x fast procedure, you'll see they did it. One time they did it on the doctor show, like live in the studio. Like, you know, somebody's like, yeah, I'll do it. And, okay. So they did it right on, and the guy just did it. And she's like, I didn't feel a thing, you know, and all that good stuff. So, you know, it's the way they demonstrate it seems pretty easy. In my opinion, if you can do a percutaneous needle tenotomy, you can do that because the probe's even thicker. Yes.
It seems like there's some evidence behind all the different things, but not accurate evidence for Neo. When you're deciding which one to recommend, what makes that decision for you?
I just go down the treatment options. So, you know, if I meet someone the first time, I'm gonna start with physical therapy if they've never had it before. Afterwards, I will, depending on. Then, unfortunately, it also becomes a financial issue because some people, you know, for example, medial lateral epicondylitis, excuse me, I can do them. It's going to be covered by insurance, and that's a good thing. But if, let's say it's Achilles, like I had a gentleman the other day who had Achilles tendinopathy, and PRP was not. A percutaneous needle tenotomy isn't covered. None of them were. So we kind of went over his treatment options, and he elected for PRP. All right. So, I mean, that's the basic. Honestly, past physical therapy and medications, or at least early on, your treatment options are almost be based on the situation, or at least the tendon that you're looking at. Unfortunately, that's the way of the world. I mean, you know, I wish I could just I would, in my personal preference, if everything was covered, I would probably go down the line of physical medications, if it's less than 3 months, with physical therapy, percutaneous needle tenotomy, PRP, and then surgery. Oh, sorry, 10x, and then surgery. If that's everything, if the world's perfect.
Do you ever see in the future, like, just thinking ahead, like PRP being able to get approval, or kind of the rigorous studies that it needs to approval? Because I can't imagine like an IRB, being able to get an IRB for pulling blood out of somebody but not using like right to have a double-blinded randomized control. So I mean, it's kind of like inherently seems like it's impossible to study.
You never know. You know, honestly, it's sometimes it's stuff that has nothing to do with medicine that gets things approved. You know, why are certain medications out there that really shouldn't be out there, but they're approved? Why are vitamins out there why are supplements out there that we cannot study? You know, I don't know. Be honest with you. I hope it gets approved because I think it's a good treatment option. I've done it 5 times and I've had 3 good results. So it's 60%. But you know, if you talk to most other people, I think Galato has she says a high percentage of success, correct? She does a lot of them. Yes, she does. But I mean, yeah, I know. That's why she's so happy. You know, no, but yeah, I mean, I would hope so, but honestly, I can't predict it. They need more studies like the one they did in the Purple Journal in 2013. If they can consistently show it's beneficial to the patients, that'd be a good thing. The big thing is getting a study, placebo-controlled double-blind study like DeVos did, somewhat to that fashion, and proving that it did work. Like if you can repeat his study, but show is beneficial, I think, you know, he only looked at neovascularization tendon structure. He didn't talk to the patient like most orthopods, right? Wait, this is being recorded. I'm sorry. I don't mean that. You know, I wish it'd be nice if he, you know, who cares? Who really gives cares about tendon structure and neovascularization? You know, your patient's there because of pain. They're not coming to you saying, hey, I have a lot of hyperemia in my tendon. Can you help me? You know, I would wonder if people are satisfied with the procedure. And I think that if you can prove that people are satisfied and it works for them, then that's something that's going to push it through. Yes.
So when you're thinking about the failure of the exercise program for a chronic tendinopathy, tendinosis, what is your time frame of saying, okay, we've tried this for this long, it's not working? My
max is 3 months. 3 months. Yeah, 3 months. If I see them, my thing is I bring them back after 6 weeks, and they say I've gotten absolutely nowhere, I usually stop at 6 weeks. Now, if someone says I'm better, but I'm not better, you know, they kind of 50-50, then I'll say, let's try it. Let's keep going. You know, you're going in the right direction. So that's, for me, 3 months is my breaking point. Anybody else? All right.
Thank you.
Thank you.